Good evening, everyone. Good evening,
Good
Dr.
evening.
Ashok.
Good evening.
Good evening, Professor Suptan.
Yeah, good evening.
Yeah, so glad you could join. Yeah. You had a meeting in the evening, huh?
Yeah. Meetings are always going on, so no problem.
Okay.
Just ended another meeting, and maybe by the time we end this, I'll join another year. No problem.
Okay, because
But, how many people are there total?
people will be joining from KJMU. They said some people from the clinical departments will be joining, as well as their entire IT department will be there. And
so, I mean, what is the number of audience you're expecting?
From KGMU, they said 8 to 10 faculty, okay, plus the IT department. They will be there.
And this is being live streamed, so I mean, anyone can see.
Yes. Dr. Dinagaran, good evening.
Good evening.
So, I mean, how did we publicize this? I mean, so that people can watch the live streaming? Did you share any link or something?
We have shared it in the informatics training workshop group. And we can share it with anyone that we want to. So like Dr. Ashok Puri has shared it with amongst his colleagues. They'll be joining. From Mahatma Gandhi Institute, others will be joining from the Institute of Health Informatics also. They will be joining. And from MUHS Nasik, some people will be joining.
Okay.
These are the ones
on YouTube. So you have a link for that YouTube live streaming?
Just share that down.
Yeah, that is Dr. Dinagaran I shared. Let me see. I mean, maybe I can share with somebody. So we have to give any particular topic for this?
Just let me just sort out my lights here. Right, this is better. I had a halo behind me. I've got
so what should I put the topic of this live stream?
It is AI in healthcare. That's the topic.
The topic is AI in healthcare. How healthcare organizations choose CDS products. We are proceeding on the same paper that was there, and we'll be following the same format that we had during the rehearsal. So while we're waiting for the other panelists to join, Dr. Tanga is traveling, but he said he will be joining. And Dr. Richa will also be joining. So she has some AI product that she wants to talk about. So that'll be good. We have some views from the ground. So just like last time, what we will do is I will introduce the topic, and then I will request the panelists to introduce themselves. So that's the best way. I think we can pick up the best things that we want to talk about. And thereafter, we have already discussed this thing, and the framework I have already shared in the document last time. The first aspect is the introduction to the topic. What is AI and ML? Dr. Ashok Puri will be handling that. Applications of AI in healthcare. If Dr. Tanga can join in, good. He can take that. Otherwise, I'll share that with both Dr. Ashok Puri and with you, Dr. Satyam. And then about the academic insights. What are the training needs for supporting artificial intelligence in healthcare? So that will be your specialty subject, Dr. Satyam. From there, we'll go on to discussing how, so once we've laid the groundwork, the introduction to artificial intelligence and what are the requirements, then we go on to the main subject, which is how do organizations select AI products for CDS? Now, what we found last time during the discussions was that the users themselves are not aware of what they want and what do they need. They are also not aware of what is there in the market. If it is there, they don't know how to test or evaluate them and how to incorporate them, how to integrate it into the existing IT infrastructure. There are cost elements also that we will discuss. The benefits that are there from using artificial intelligence in our healthcare system, and what are some of the issues which are there. So these are the operational attitudes that we will discuss. And then from these, we'll see what kind of academic insights we can derive out of this. So those become focus areas for training in healthcare informatics when we focus on artificial intelligence. I hope we all agree on the framework. So just to revise, I've pulled out the framework that I had shared earlier in the group. Introduction, develop a common understanding for the forum. What is AI? Uses of AI in healthcare, use case scenarios, and the present academic environment. And then we go deeper into the subject. How do health systems select AI? Which products to deploy? What are the cost factors in implementation? And value proposition of the products. Then translating the observations to the need assessment for Indian healthcare organizations, and how can academia meet these needs. Once we've finished our discussions, that will be about 30 minutes in all, then we will invite the expert comments, depending on who all is available. Dr. Moidu is traveling, but he said as soon as he is able to connect, he will join in. And whatever questions we receive, we will take it on from there. I'm trying to reach Tanga. Dr. Dinagaran,
Yes.
we'll request someone to take down the questions from the chat and the Q&A box, and that can be forwarded to me on the WhatsApp, so I can put it to the panel then.
Sure.
Thank you so much. Thank you. There's some echo from your on your line. Maybe, I don't know, maybe two connections in the same room or something. Good evening, Richa ji. Welcome.
Good evening, sir.
Good evening. You are already familiar with the framework. You were
Yes.
part of the rehearsal last time,
Right, right.
right? So I will be reaching out to you on use case scenarios of
Okay.
artificial intelligence in healthcare, right?
Is it? Okay.
Okay. Yeah. So along with Dr. Ashok Puri and Dr. Satyan, I'll be reaching out to you as well. Okay.
Right,
So
right.
what we'll try to do is, rather than one person speaking, I'll keep rolling the questions to all the panelists. Yeah, since you've just joined, for your benefit, after I introduce the subject in the beginning, I'll be asking the panelists to introduce themselves one by one.
Okay.
Right. So
So,
maybe you can put your thoughts together.
Okay. I'm not supposed to be the panelist.
You are a panelist. Yeah. Right.
Okay. Okay. So use case scenarios, that's it, in AI, right?
Yeah. Where all we can use artificial intelligence in healthcare.
Right, right.
Right.
From our team, some clinicians would be joining in.
Great.
And I had a word with Puri sir as well, our VC sir. So maybe he'll join in a while. And
great.
we also have some technical people from our team.
Great.
Developers and all who are actually looking into the data of the HIS.
Right.
So they also have that, they should know the interaction between the clinician and the technical. So
oh, yes. Yeah. Yeah. As I don't know if Dr. Moidu is able to join yet, but he always gives the example of tribal leadership. That's a lovely book. If you've not picked it up till now,
right.
I would also recommend that everyone should pick up this book. So what he says always is, and he always emphasizes this, that the IT team should be part of the clinical team. So there should be no lines there saying that I am IT and I'm not. Once you're working in the hospital environment, you are a healthcare worker. So you are part of the tribe. You are a healthcare worker. You have to think like them. And this is one of the things that he mentioned during the rehearsal round also, that the IT team should be part of the clinical grand rounds when they're conducted in the hospital.
Yes, yes. Agreed.
Yeah. Good evening, sir. Am I seeing General A.K. Singh?
Joined.
Welcome, sir. We are honored.
Honored, yeah.
I'll be reaching out to you for insights as well, sir.
Insight is that how do I get the IT team under me? Yo, Richa,
Yes,
how do you feel कि आ जाएगी हमारे पास?
Sir, you already have the IT team under you, isn't it?
No. I've got the health informatics team with me.
Okay. So then we can have KGMU and Mahatma Gandhi blended HI and IT team together.
That will be fine.
So I'm working on the MOU also, sir.
भेज दो. My boys are, even the faculty is willing to come and work there.
Yes, sir.
Okay.
I'll share a draft with you. I'm just working on
it. I think Dr. Moidu has just joined.
Yes, sir. So from from our KGMU, we have Dr. Malhotra. So he's a neurologist. And sir is a passionate researcher as well. So.
Welcome, Dr. Malhotra. Welcome. Good evening, sir. Dr. Moidu has also joined. I'm so happy that you were able to join despite your travel and busy schedule today, sir. Dr. Dinagaran, I think the panel is here, and yeah, I think Tanga is trying to join. He's just sending a message. Let's see what he's saying.
I've just shared the link with Dr. Tanga.
I've sent him the link.
Yeah.
I think Dr. Moidu was trying to speak, but he's muted.
I know I was trying to
Okay.
learn how to use the Zoom again.
Okay.
Good evening, sir.
Hi. How are you, Dr. Ryan?
I'm fine, Dr. Moidu. How are you?
Good. Let us look forward to what Ashok Puri, Supten Dada, and Richa ji do.
Sure.
And the important thing is we have to look at what Richa says. How is she going to make the decisions? Because it is easy to talk theory. It is very hard to walk the walk.
So that is the real struggle. That's why I was a bit disappointed in the last, because when it comes to implementation, it's you work with a yardstick.
Well, you got a yardstick to beat people up. Don't worry. You are beating people up. Nobody's beating you up.
Abhishek, who else is joining? Good evening, Abhishek.
Good evening, sir. Anisha is also joined, sir. Anisha from.
We have Dr. Sumaira with us. She's from Department of Pathology, and she's also a member of IT cell of KGMU.
Actually, Richard, did you have a chat with, since our last conversation with Bipin? Because I'm going to ask him tomorrow for a time. I need to chat with him. So
I think he will be joining. I just had a word with him just a few minutes back. He said he will be joining in the meeting.
Excellent. Because I would like to, we had a very good visit to the two other institutions apart from Mahatma Gandhi where they are working hard. And as Chomu was saying, everybody wants to get on this bandwagon. At St. John's, they had worked very hard and we've got a lot of framework for the badges ready. So it will be good to see. Tanga Prabhu is in a bus. Or is he in a plane? Tanga Babu? Tanga Babu. Your smile is good. How about unmuting?
He's on a train, so he just said he would be on mute.
Okay. Good. Between Tanga and Apollo Vision, that is able and payable, to Richa and the team in KGMC doing it as soon as they can. Good. I shall now maintain silence.
Right. So I think the panel is, everyone is here now. So good evening and a very warm welcome to everyone. Sir, with your permission, should we start now? Or? So a very warm welcome to the distinguished experts on the panel. And I'd also like to thank the St. John's Research Institute for the technical support. And a warm welcome to the audience who have joined us. Your very presence here means that you are enthusiasts in this field and are physician champions and technical champions who will be taking the cause of artificial intelligence and healthcare informatics forward. By default, the mic of the participants is on mute. If you wish to share something, please raise your hand and the host will permit you. We'll take the questions at the end. Please share your questions in the chat box or the Q&A. With this, let me invite the panelists to give a brief introduction about themselves. We'll begin with Dr. Ashok Puri.
Well, thank you, Rajiv, and good evening to everybody. I am an ophthalmologist, and after almost 35 years of phacoemulsification, the non-stitch cataract surgery and laser surgery for getting rid of glasses, I've got hooked on to artificial intelligence. After a course at the Indian Institute of Science, I've been into making deep learning models for images and even using natural language processing and so on. And gradually it's becoming a passion for me.
Great. So you are a physician champion. You have done deep work in the clinical side, and now you are into deep learning as well. Welcome to the panel. I'll request Professor Suptan Sarvadikari to give a brief introduction.
Good evening, everyone. I think it's a great honor and privilege to be here. Another thing I think probably Ryan can help. Other than the attendees in the Zoom, I think there are lots of them who are watching the YouTube live. So if you can also get a count from there, I think that would be great. Although we may not be able to retrieve the question from there. Back to the introduction, I am Suptan Sarvadikari, a medical doctor with a PhD in biomedical engineering, and I've been trying to establish the academic discipline of health informatics in India. So I've been the first project director for the Center for Health Informatics with the Ministry of Health and Family Welfare from 2013 to 17. And we have developed the National Health Portal, and we're also involved with the starting of the various e-health activities under the banner of the Ministry of Health and Family Welfare. I've been mostly an academician, and I've been involved with the Manipal group as well as the Amrita group, the IIT Kharagpur, the Apollo group, the PSG group, and so on. In fact, currently I'm visiting faculty in multiple institutes. Right now, I'm trying to set up a digital research center at Shantiniketan Medical College. I'm definitely looking forward to learn a lot from all of you during the discussions. Over to you, Dr. Rajiv.
Thank you, Professor Suptan. You have had a long journey in the digital health field, and I'm sure there are many gems that you've picked up along the way, and we'll request you to share them with us as we go along. I'll now reach out to Dr. Richa Khanna. Would you please give a brief introduction?
Yeah, a very good evening to everyone. So I'm Dr. Richa Khanna. I'm a pediatric dentist by profession, and I'm taking care of the information technology cell of King George Medical University, Lucknow. So I have a brief experience, a small experience as the in charge of IT cell in KGMU, and I've been trying to integrate the real world with the whatever experience I'm getting from this elite group of health informatics. Thank you very much.
Thank you, Dr. Richa. You are actually working at the cusp of clinical and IT. So you are exposed to the real world and the opportunities which are there in the real world. So a very warm welcome to you on the panel.
Thank you.
And I'll try to reach out to Dr. Tanga Prabhu. Dr. Tanga, if you'll unmute and give a brief introduction. I know you're in a noisy environment, but this will give us a chance to test your audio system as well. Okay, Dr. Tanga is requesting that he's unable to speak at the moment. Right.
Yes, beta.
Right. So with this brief introduction, let's dive into the subject. What we are planning to do today is explore the organizational attitudes to artificial intelligence and clinical decision support systems. And from this, we'll try to develop academic insights to meet the needs of healthcare organizations. We already have two keywords here. Keywords, buzzwords, whatever you want to call it, artificial intelligence and clinical decision support. I'll reach out to Dr. Ashok Puri to give us a brief introduction to the jargon, to the technical terms that we are going to be exposed to during this discussion so that all of us are on the same platform when we are discussing things. Dr. Ashok Puri.
Well, thank you very much. I hope my screen is visible to all.
Yes.
Yeah. So let's go bang on into what is artificial intelligence. In contrast to human intelligence or natural intelligence, artificial means that it is not naturally present but crafted by man. And intelligence refers to reasoning, learning, perception, problem solving, and linguistic intelligence. Now, give any of this to a machine or a computer that makes the machine intelligent. And therefore, it begins to perform tasks like what humans do using their intelligence. This kind of a machine never gets tired, works day in and day out, day, night, every time, and it has no emotions. It is said that a machine or an autopilot can handle a missile fired at Air Force One better than the human pilot. Now, coming to artificial intelligence as a domain, early methods were there almost 60, 70 years back also, where machines were made intelligent, but with explicit programming, exhaustive code, they were rule-based, and they did not improve with time. So there were a lot of exceptions that kept on coming. I mean, you show hundreds of images of dogs, and then you show another one which the machine hasn't seen. It's a little different. You'll have to program it specifically again. So that is how it used to take a long time, and it was very cumbersome. Then came machine learning, where the machine or the algorithm learned from the data without being explicitly programmed. And the performance kept on improving with more and more data and more training with time. Another a subset of deep learning, a subset of machine learning is deep learning, where the architecture is inspired by the human brain, that is the neuronal networks, and there are no features which are given. The algorithm automatically extracts the features which are required by it to make a decision. Now, coming to the concepts and the jargon, which I want to familiarize you with all, that includes many things, including that there is a project lifestyle for artificial intelligence, there is a framework for evaluation, there is a need for review, and there is a need for audit of artificial intelligence. Now, we talk of AI or artificial intelligence models. Now, what is a model? Model is a function or a relation. Now, you have data X and a target output Y. What is the relation between them? F of X. F into X, that is, gives you the target or the output Y. So what do we do in training? We show the model 2 and then show the answer as 6. We show the model 5 and show the answer as 15. Show the model 10 and show the answer as 30. The model has to find out the relation or F, and which is 3. Once it recognizes that pattern, whatever you give it 100, it'll give you 300. So this is how the machine learns how to give you useful information. But of course, it's not as simple as this. These relations are not linear generally. They're all non-linear relationships, which are actually represented in a very high dimensions, which are impossible for us to even think of. I mean, it's just an abstract that goes on. Abstraction. These are all vectors, matrix, multiplications, and additions which are going on. Now, there are various types of models, discriminative and generative models. The method by which they are made to learn can be supervised, unsupervised, or reinforcement learning. What we talk of today, including these including these self-driving cars, are all artificial narrow intelligence. We are striving to go on to artificial general intelligence, which is just like how humans go on with their intelligence, but that we have not reached. Sometime later in the future. A very common model, which I'd like to show you how it works, is an image classification model. You give an image to a model, it is converted to numbers, goes through the model, which has been trained on those kinds of images, and all after the mathematical calculations, it gives you an output, which is again a number. And after that, you convert it into the class so that we are able to understand. Now, what is the output of such a model? It's a list of probabilities. It's like a differential diagnosis. That means a list of probabilities of all the classes on which the model was trained. And the probability, the highest probability, or the class with highest probability, is given as the diagnosis. Now, the process of life cycle of an AI model. The first thing that we do is identify the business problem, collect the data, prepare the data, build the model, test and evaluate the model, deploy it, govern it, maintain it, monitor it. And the most important thing in this is the quality of data. We'll be talking about frameworks for evaluations. So what do we want to see before we select a model. One, it should be versatile. That means it should be able to work with different kinds of data, whether it is text or images or numbers, or it should work with different size of data, like the resolution and length of text, or it should work with real-time data, streaming data. That means it should work with multimodal data and give you the output. Sustainability refers to a continuous development, training, and deployment of a prolonged period of deployment of this model for a prolonged period. Now, you have to minimize the downtime so that the users are not affected when the model retraining and all goes on. The performance of the model depends on various factors, but what we look for are the relevant metrics like accuracy, precision, recall, and F1 score. Remember, recall is very important in healthcare because we don't want to miss a diagnosis. We don't want to have any false negatives. Now, the fourth one is explainability. This actually tells us how the model interpreted the predicted results, or interpreted the whole image or whatever it was given to the model to give you the results. And therefore, this explainability increases the confidence of the user who is using the model. Now, suppose you give an image to the model like what has been shown here and ask, is there a cat? The model answers yes. We don't want to know how, we don't want the mathematical calculations, but we want to know why. And then the model explains, showing you what are the areas or what patterns it saw in order to give a diagnosis as cat. And therefore, we know that it is right. Now, this is how we develop trust in a model. So a clinician has to keep reviewing the models, and there is an audit of the model also, which is necessary because there may be some biases that get introduced in due course of time with different data, which should not be there. So I think this is just to give an idea of artificial intelligence and what and how are we going to use it. Thank you.
Thank you very much, Dr. Ashok. That was very lucid, very you have simplified such complex terminologies for all our audience. And you've correctly brought out 3-4 factors that we need to be aware of. One is the versatility, the sustainability, the performance, the explainability. If the clinician doesn't know what's happening in the black box, they obviously will not have trust or confidence in it, because how much ever the machine may tell you that I am right, unless I know how you have arrived at the decision, definitely I will not have confidence. And we are going to take, the clinicians are going to take life and death decisions. So they have to have that confidence. Thank you very much. We'll now move forward, and let me reach out to Dr. Richa. Dr. Richa, can you share some examples of use of artificial intelligence in healthcare?
So being a dentist, the first example that comes to my mind is caries diagnosis, because I have been into, this is the bread and butter of a dentist day in and day out. So depending on, we regularly use IOP X-rays, orthopontograms, and many other radiographs that can accurately actually predict diagnosis. And there is reported literature where, based on this imaging, artificial intelligence has been used to, predict the depth, the prognosis, and even the diagnosis of the disease. Similarly, we in our institute, I think some of the clinicians from our institute have already joined. In the COVID times, our institute, KGMU, had worked on the medical imaging of your chest X-rays, CT scans of chest, and they have predicted prognosis of COVID and the disease severity based on that, using artificial intelligence. Now, these are some of the clinical examples which we call the clinical HI, that is the diagnostics of the disease. But besides that, I also see some, within the clinical HI, there may be assisted prescriptions as well. When we are writing online prescriptions, with the help of HI, we can have assistant prescription or an automated prescription format, which though is not a practically possible in our scenario right now, but maybe in future. In the non-clinical HI aspect also, I see a lot of potential when I look at the data that is filled in our HIS. That is a cost analysis for our schemes which are usually cashless, or which are supported or funded by the government. Now within this, we have the entire billing modules in our HIS, where the billing patterns can be used to predict some kind of the expected costs of these cashless schemes, and that can help the policymakers and deciding on the budgets, etc. This is one aspect. Second is the inventory management. Again, that is a non-clinical HI, where based upon what is the usage, what kind of surgical consumables, drugs, etc. are being utilized in our different wards, we can predict the management, budget our future purchases. Again, the AI can come into play and help the clinicians and the non-clinicians in the healthcare sector like this.
Thank you very much, Dr. Richa. You brought in two very distinct possibilities for use. One is the clinical and the second is the non-clinical aspects for use of artificial intelligence. So artificial intelligence is not only for clinical decision support, and clinical decision support very often depends on some non-clinical inputs as well. The participation of a patient in a healthcare, in a long-term treatment regimen may depend. We have seen so many patients who drop out of treatment because they think that the treatment is not affordable. A large proportion of our populations depends on out-of-pocket expenditure, OOP, as it is called. There's a very nice use case scenario. WHO has approved autonomous use of chest X-ray for screening of tuberculosis. And there's this company which has been approved by WHO. They are able to arrive at a diagnosis using artificial intelligence within 20 to 40 seconds. Compare this to the scenario that exists, whereby a person who has some symptoms comes in for and is advised a chest X-ray. The chest X-ray is then seen by a radiologist, and the person comes in the next day, a report is given, then he's sent for a sputum test. What they're doing in this model now is 20 to 40 seconds to arrive at a screening diagnosis. Immediately a sputum sample is taken, the person is sent for gene expert testing. Within 1 hour, the patient has a diagnosis, and then is sent to the clinician for starting the treatment, which means in one single visit, you're able to start the treatment for the patient, unlike the previous scenario. We are also seeing early diagnosis of cancers. What used to be diagnosed in stage 3 and stage 4 is now being diagnosed in stage 1 and stage 2, and those possibilities are also there. There are products in the market for oral carcinoma, breast carcinoma, chest, lung carcinoma, etc. So we have seen the benefits here. And let me reach out to Dr. Sutin here. Professor Sutin, what kind of academic environment exists at the moment for supporting artificial intelligence in the healthcare environment?
Artificial intelligence or machine intelligence or machine learning, these are, as academic disciplines, are very much there mostly in the engineering education setups. So all the institutes for engineering education usually have either full courses or maybe electives and like that. But if you come into healthcare, we don't really have much of a formal courseware. In fact, in some of the cases where we are having courses on health informatics or analytics, there are some elective courses maybe there. I'll just share an anecdote I shared during the rehearsal as well a few days back. So I was sitting for in a PhD doctoral committee. They were submitting the PhD proposals, and it's a technology university. And the candidate was actually from healthcare background. But it so happened that, I mean, the candidate had one supervisor from healthcare domain, one supervisor from a IT or hardcore engineering domain. Yet they were not very clear, the candidate or the supervisors. I mean, they put in some very generic things. They were trying to do evaluation of telemedicine services, and they said they're going to use predictive analytics using machine learning. That really means nothing. That's too non-specific, too broad. And then obviously, I mean, we also asked, I mean, exactly what would you like to predict? What would you like to analyze? I mean, applying machine learning tools, it's probably the easiest part. But then what exactly are you going to look for? In other words, I mean, the health data, the digital health data. So health data literacy, digital health literacy, I think that's the most biggest challenge. And in fact, that is the missing part in most academic curricula. So I think Dr. Moidu has been always stressing on that. And it's very, very important. I mean, when we devise any curricula, when we offer courses, we must make sure that the people, irrespective of the background they come, they must have minimum health data literacy. Otherwise, I think if you don't know what data would help your analysis or what you want to analyze, I mean, what are you going to collect? It may not serve any purpose at all. So I think we need to really look at the basics very seriously. That's my take.
Thank you very much. You've really hit the nail on the head. We are surrounded by jargon and enamored by the jargon. And like a jaybird, which finds a golden shiny object, we keep pecking on it without even realizing whether that is food, whether it is useful or not. Would you recommend introducing some kind of data analytics at the undergraduate level in the medical curriculum?
I mean, some analytics is already there. If you look at the community medicine syllabus, so there's some sort of analytics, some sort of data collection is there. But the problem is, as I said, I mean, the health data literacy part, I mean, which data is really going to serve which purpose? That is what becomes very elusive. I'll give us very simple example. I mean, if it's a newborn child, you are going to track the growth over the first year. And if you decide that the data that I'm going to collect is the number of hairs on his head, now, would that be a useful data? If you collect the height only or the weight only, that may be much more useful than if you select this, because this is absolutely non-specific and doesn't reflect anything. It varies with every individual. So that's the very important thing. I mean, we often, I mean, this one I gave probably a very grotesque example, which is very apparent that this is not the right thing. But the most of the times, what we tend to do is collect some data, maybe correctly, rigorously, high quality, but that is not what data would actually serve our purpose, the research question that we are trying to look at.
Right. So thank you very much. So let's summarize what we have achieved in the first round. Artificial intelligence has immense possibilities, clinical as well as non-clinical, and artificial intelligence serves to extend the capabilities of the doctors. It pushes the boundaries of human performance, and at the same time, it can democratize medical knowledge and excellence. Dr. Puri, would you agree that because of artificial intelligence and telemedicine, an ophthalmologist need not be everywhere in the rural area? Images can be captured, screened, and shared wherever required. What are your thoughts on this?
Yeah, that's true. I mean, images can be captured and shared, but sometimes when the internet connectivity is not good, it's better that the model is right at the point of care itself. I mean, you have these so many of these GPUs, small ones available, which can be attached to a fundus camera, and you have a trained model in it. The model sees the image and gives a diagnosis, so that triage can be done immediately there itself, and the patients who have to be sent for to the main hospital can be decided then and there itself, and you don't need the doctor available at every time. So you don't need the doctor available at every time. I mean, whenever you want to send the images, I mean, it can be totally an asynchronous kind of dealing with the patient. I mean, at any time the patient walks in, say in a village, and then the diagnosis is there just because the machine has got its own capabilities to give the diagnosis then and there itself. So no transmission problems, nothing at all.
You highlighted a very important issue, the reliability of connectivity, which is essential for any kind of teleconsult that is there. Thank you, Dr. Ashok. Moving on, we are looking at clinical decision support systems. Sorry, I had ordered some medicines for my mother and the person has just arrived. So sorry about this interruption. So moving on, clinical decision support systems are not only for clinical aspects, as Dr. Richa was bringing out, it is also for non-clinical aspects. There is a, to share with you, during this COVID crisis, we had very limited number of ICU beds available. So artificial intelligence was also used for triaging the patients. The triage helped you decide which patients needed ICU treatment and who could do without that. So you could maximize the available resources. In Australia, they've used this artificial intelligence to predict where the next wave is likely to be there. It's a very large country. The area is about twice that of India, very sparsely populated, very few resources, but by predicting where the next wave was going to be there, they were able to move their ventilators and the trained staff from one location to another. So these are some multiple different dimensions in which artificial intelligence can be used. Moving on, let's see how AI products are selected by healthcare organizations. Now, I was reading an NHGM paper, New England Journal of Medicine. I was reading a paper. He says the clinicians are wary of artificial intelligence products because some of them, most of them are actually seen as solutions looking for problems to solve. So the vendor has come to you with some product and is trying to give it to you, whereas the clinician has a different need altogether. There's a gap between what is available and what is required. So how do healthcare organizations select the artificial intelligence products that they need? Dr. Richa, would you like to come in on this?
Yes, sir. As you said, most of the time it is the solution reaching the problem and not knowing whether the solution actually will going to satisfy that problem or not. So as we were also discussing in the previous sessions also, most of the clinicians need a lot of health data literacy, and we need a bridge between the vendor and the clinician. Maybe there is the potential of HI who can actually, coordinate between the solution and the problem, because most of the time our clinicians are not knowing which problems can have potential AI solutions, and the solution providers are not knowing what is the actual problem with the clinicians for which they can give the solutions. So my take on this is, yes, maybe some of the clinicians have a very nice research question and they try to find out the solution and get to the vendor, get their problem solved. But most of the time, it is by chance that the solution is meeting the problem, most of the times.
Thank you, Dr. Richa. I'd like to bring in Dr. Khalid Moidu on this. Sir, will you please share from your rich experience in this? So you're mute.
My apologies for being mute. But the fact is, as we are looking at it from an academic perspective and thinking the objectives of putting such a course in the process and bringing such work within our curriculum collaborative, I like the way Ashok and the team went through and gave some good openings. I just want to add one thing. I'm a classifier. I put things in boxes. And the two boxes with diagnostic decision-making and therapeutic decision-making is where AI is applied. In AI, in therapeutic thing, it is more structured and more precise because you're actually ensuring whether a therapy can be delivered in the circumstances of the situation which is described through lab results, etc. Whereas it comes to diagnostic decision making, we are still sometimes go well and sometimes we don't do so well. So it is not left to chance. There are a lot of things that can happen. True value comes in enabling and empowering a less experienced doctor with a decision that the experienced make without thinking. So I would recommend and ask you, Rajiv, to ask this panel how they would like to reflect on it and how they would like to, since they are working on these models within the Indian context, and since our curriculum effort is in the Indian context, to give us more impressions on that side.
Thank you very much, sir. You have brought things into focus here. I'll reach out to Dr. Supten here. How can we empower our junior doctors or doctors in the periphery by using AI tools, and what kind of training needs would be required for this?
Yeah, I think there are already some decision support systems available in the form of apps or through tablets. And some of the hospitals do use them, particularly in the emergency department. However, the point is, in fact, the younger doctors or the students, they are maybe even more tech savvy and they are using the computers for various purposes. However, what happens is, like in the classical case of, if we take the Watson for oncology, while the brains who made that, they were of undisputed level, but when it came to the application, and it's not just it failed in India, it failed in the US as well. So there are multiple reasons. The clinical decision support, suppose we want people to get trained in it and use it. But I think validation, the clinical validation itself is often lacking. Often because of the market forces we may have, because it's coming from a big house, a well-known company, a well-known vendor, and so we go for it. Oh yeah, they are proven so well in so many other fields. So I think that's the most important thing. And that brings us back to the very question this panel is dealing on. How do you really choose the right solution? The right solutions, if they're not available off the shelf, we need to develop, and that's where the research part comes in. And that's where we all need to work together, irrespective of the domain, whether it's technology, healthcare, cognitive sciences, and all the things, because communication definitely plays a big role. So coming back to your question, what sort of training? Training would be obviously, first to see that we have a decision support system which is actually usable in the population that we are trying to use. If so, most of the systems probably, they are fairly easy to use. You don't really need a lot of training. And the adoption increases when you get the benefits. You see, yeah, because I did that, I could save lives, or I could save the sufferings of so many patients. And then word of mouth also spreads. So I think training part for using the things is not really so much important or required, but training is required to select the right system, and more important, to develop the right system.
You brought a very important consideration into the discussion now. We need tools for clinical validation. And artificial intelligence, although it's been around for some time, for quite some time, as was brought out by Dr. Puri, yet tools for evaluating, rubrics for evaluating these products are very few, and these also need to be developed. And that's where the role of regulators also comes in. Dr. Ashok Puri, would you like to share your thoughts on how artificial intelligence can be used to enable the less experienced doctors?
No, the doctors have to be taught how to use AI and how to interpret what the AI is telling them. And like I mentioned in one of my slides, that when an image is given to the model, what does it give you? It gives you a list of probabilities. That's exactly how we try to diagnose something. The probability is this. I mean, we give a differential diagnosis, and the one which is most likely is the first diagnosis. And so this is one part that they have to understand. Once the doctors begin to understand that, the second thing is they should be involved in the development of the AI itself. So that makes things easy for them to get very familiar with it. And they have to understand one thing, that like we are trying to empower the patient so that he is involved in the decision making. He is an informed patient, and then he sits with the doctor for all the decision, for the diagnosis and for the treatment. Now we have to have a concept in our mind that there's going to be a shared decision making, a shared one. That means there are three people involved in it: the doctor, the patient, and the third person is the computer. So that's the AI which is going to give you insights. So if AI has, I mean, if the system has been developed by some very senior and good doctors, I mean, it's definitely, and it has been validated that it's giving a good output. So then the doctors will actually have a senior or a buddy or a colleague with them with whom they can interact. And if you want to maintain some standards of healthcare, then the AI can be developed in such a way that the standard is maintained. If the doctor is a little sleepy, or he is very tired of a long duty or something like that, he may tend to miss something. But then the AI might still see to it that he doesn't miss that. So for the patient, it's going to be a win-win situation. And the doctor can always use the AI to help him at certain situations where he needs them. I mean, basically, the doctor doesn't want the AI system to second his diagnosis where he is very certain. It's only where the doctor is uncertain. Can he have another opinion available to him immediately at hand? And that's where the AI comes in. So once the doctors begin to work with this, it's very important. I mean, it's very useful for them. And it is very important that we started right from the beginning. Otherwise, what will happen is what the mistakes that were made when EHR had come. It had come for billing, and then it was pushed onto the doctors, and it led to a lot of unacceptable consequences, which created more problems for the doctors and the doctor-patient relationship. So that's why we must get on hand in hand with the doctors so that they begin to use AI right at the time, the beginning of its adoption itself.
Right. Thank you, Dr. Puri. So we have arrived at 3-4 very important conclusions
I would
here.
like to pitch in here.
One is, the first is that the AI should be solving a high priority issue in the domain. The second thing is there should be ease of use. So clinical utility, ease of use should be there, and the AI is not required for routine functioning. It is required in the conditions of medical uncertainty. You have a 50-year-old with 95% oxygen saturation, we're talking in COVID scenario, and you have another 37-year-old who's got 92% oxygen saturation. Who should be admitted? AI can help you with its algorithms in this kind of decision making. That's what Dr. Puri was bringing out in the conditions of medical uncertainty. We are coming towards the end of the discussion. I'll request everyone to share your questions in the chat box, in the Q&A, while we move on to the last segment of the discussion. And what we are going to look at is what are the cost elements which are there when you're looking at deploying an artificial intelligence solution in a hospital. Dr. Richa, would you like to say something?
So coming from the government background, cost is a issue for we have to consider the cost factor for AI solutions again, because all these solutions mostly, if you see, are expensive. And when it comes to choosing by the clinicians, the benefit to cost ratio, the worth to cost ratio has to be looked upon, because that solution should be able to prove the worth, the cost we are putting it into. So mostly we, as clinicians, we look forward for solutions which are cost effective, help us in decision making, but they should be cost effective, and then only they will be well grasped and adopted by our clinicians.
Thank you. So in the cost centers for adoption of any new product, besides the product cost, there are cost of the staff who will be using it, testing it, evaluating it. And we also have existing HIS and EHR systems in the hospital. So there is a cost for integration and retrofitting also, which needs to be looked at. And then there is the cost of continuous testing of the product during its life cycle, validating its results as well. Now, when we see a product, we have to look at its direct benefits and the indirect benefits. Direct benefits, as has been brought out, cost saving. You can see more patients because you have a faster turnaround time. You can make earlier diagnosis. Indirect savings are in the field of patient satisfaction and brand awareness. But then there are some issues, some barriers to introduction of any such IT product in our healthcare organizations. Professor Supten, would you like to pitch in here?
Yeah, I think another issue which we have so far not dealt with, but it's definitely a very important issue, and that relates to the safety. In other words, ethical practices. Now, when we talk about ethical practices during the development of the AI system for healthcare, ethical practices during the use of the AI systems in healthcare, and also ethical practices are required for the training part. Because I think there's a lot of discrimination, whether it's in the training, and when we talk about development and whether profiteering versus safety, that thing comes in. And same about use. I mean, like whether, like the example you give, the triage, is it really worth it? Or should we rather try to admit both the patients rather than leave one out? So I think these issues also, I mean, cost and safety and the ethical part, I think that also needs to be kept in mind.
That's a very important consideration. What the cost of a false negative report is immense for a patient. It can be a huge cost for a patient and the family. And when we are talking of ethical considerations, we also need to see whether the product being brought in is suitable for our population or not. We see a lot of Western vendors who come in with their products, but these products have not been tested on Indian patients. And even in India, we have such diversity that we need to be sure that the product is the correct product for our demographics. Moving on, when you implement an AI product, an AI solution, implementing it is the easier thing. Dr. Ashok Puri, I'll reach out to you here. Implementing the thing, you bring in a technical team, the technical team installs it, does some hand-holding, and implements it. But the real problem starts after that. What do you think, Dr. Puri?
Yes, that's very true, because it's the action that is going to be taken after this implementation has been done. Well, are you really using it for some purpose? Or is it just that you're trying to increase the brand value of your clinic or hospital, saying that, oh, we use AI, but then what has it done? If it has given a diagnosis, what is the use of it? I'll give you a simple example. There is one, people are working on some products like a patient goes to say for an X-ray or an MRI or CT scan. If there is an algorithm which can see that the images which have been taken are good or of good quality, so then that shows that yes, the patient will not have to come back for a repeat scan. Especially in pediatric patients, there may be a little movement during MRI, and if the algorithm tells you, oh, there's the images are not very clear, so you don't have to call the patient again and give a sedation and all that. So those things really help. So there is an action which is being taken, and it is useful. But otherwise, if the product is just going to tell you certain things, yeah, it's fine, but then you don't take an action, so then it makes no sense to use it at all.
Right. Thank you very much. So that brings us to the very important issue of quality control in healthcare, and the issue of ethics, privacy, and data security. Dr. Supten has already highlighted it. I think we are coming towards the end of our time, and we would like to save some time for question answers and inputs. Dr. Shrikant, I'll come to you in a moment. Let me just wrap up this module here. So in conclusion, what we find is a scenario where the users are largely not aware of the possibilities and the products. There is no well-defined, systematic, standardized framework to identify, evaluate, or select the products. But what we need is the product must solve a priority problem. It should be able to function during conditions of medical uncertainty. The product should be tested on own population. And now, every organization, whether it's a government organization or it's a private organization, a private hospital, they're looking at a positive return on investment. They are saying, what is the value proposition of this product? What will be the timelines of return on investment? How does this product add to my bottom line? Is it sustainable? Am I getting it only for showing off that I have such a high-fi product, or as Dr. Puri was saying, or is it actually going to change the outcomes in my hospital? And finally, we have a product which is implemented, but this outcomes, the output of the AI product will change the workflow in the hospital, will change the way the doctor will be approaching the patient. And that becomes the more difficult component, because the doctors are used to working in a certain manner, and an artificial intelligence product comes in and says, look, you are wrong here, you need to change the workflow. And that cultural change is also a challenge. Issue of privacy and data security have already been mentioned. And as Dr. Supten was saying, the issue of data literacy is very important. So I will conclude the session here, but before concluding, Dr. Puri, your final concluding thoughts.
Well, AI is definitely going to come into healthcare in a big way. So it's time for doctors to learn about it, understand it, and start adopting it. Use it like a buddy or a colleague, which goes hand in hand with you, make shared decisions. I mean, this is all from a clinician point of view, and therefore go hand in hand with it and adopt it. That's all.
Thank you. Thank you. That's a very encouraging voice from a surgeon. And you will be a good physician champion to tell the other doctors about the possibilities, and that it is possible to use it, as they say, ki ek bar try to karke dekh. Now, as Dr. Moidu was saying, there is no denying that AI is the future of healthcare. However, the AI technologies won't implement themselves. They will require considerable translation expertise. And for that, I'll reach out to Professor Supten. How do we transform our educational system?
I think we need to tell people the simple thing that either brain or either computer alone are less than brain and computer together. So the question that often people ask, that whether AI is going to replace doctors, the obvious answer is no. But AI is certainly going, I mean, the doctors, those who do not use AI are certainly going to be replaced by doctors who are using AI, and only they would survive. So that's how we need to look at it. This attitudinal change has to come in. This, educational awareness needs to be there, because either brain or either AI alone is not sufficient. But if the two work together synchronously, certainly you are going to get better health outcomes.
Thank you. Thank you. So AI will survive, but doctors who do not use AI and IT may find it difficult to survive. I think that's a fair warning to everyone here. Dr. Richa, your concluding thoughts?
I look forward to more data completion in my institute for more potential solutions that we can have. And also with ABDM coming in, I think there is a huge potential of artificial intelligence waiting for all of us.
Thank you. I must compliment you that so many clinicians from your team have, from the KGMU team, have joined this discussion, which shows a very positive movement in the hospital system there. So my concluding thoughts, healthcare delivery is complex. New inputs are always challenging to implement. Hence, there is a tension between opportunity and reality facing artificial intelligence as well. There were challenges, if I recall correctly, when Lennec introduced stethoscope, the doctor said, what could be the practical use of this item? It took almost, yeah. So the same way, health informatics, artificial intelligence, people are already realizing it, and the products are getting implemented. But healthcare organizations will always look at the value proposition, not only the clinical outcomes, but also what AI adds to the bottom line. Its benefits versus costs and sustainability. With this, I would like to thank all the panelists for sharing their time and valuable insights. And shall we open it up to questions? I have one input here from Dr. Shrikant, and he's saying there has to be prioritized areas to implement AI. We fully agree, and AI has to address high priority problems. The need for AI will depend on managerial decisions. Yes, that was my concluding thought here, where we said that it is not only clinical outcomes, but also what AI adds to its bottom line. Is there something else you wanted to say, Dr. Shrikant? Dr. Shrikant? Okay, I don't, probably he's not able to respond. Dr. A.K. Singh has mentioned that Dr. Ashok Puri's slide had data preparation. So the basics have to be covered before going in for any system. Stick to the basics, data, and data literacy. Very true, we have to stick to the basics. General A.K. Singh, if you are there, sir, we'd like to hear your thoughts on this.
Very, very much. Can you hear me?
Yes, sir.
Now the question is, where all these things will come and take a lot of time, and they'll be simultaneously coming to you. Artificial intelligence will move in, health informatics will come in, HIS will come in, and all these have a shelf life. Now the basics of all this, if you have a shelf life of an HIS for 5 years or 6 years, the return on investment is going to be a major thing, major thing. And the decision making always comes from the top. We put it in and they select the product. Are they data literate? They have to be data literate to understand why are they selecting this product. And last May, the scapegoat is the IT guy who recommended, let's purchase this. And it doesn't answer the question. So to me, as far as I'm concerned, data literacy and data culture has to be changed in a society, in an organization. Thank you.
Thank you very much for your insight, sir. Very valuable points there. Right. So we'll open it up for questions. If there's any questions, any thoughts anyone would like to share here. While we are waiting for questions, I'll request Dr. Moidu to share his thoughts. Dr. Moidu, sir, if you can hear me, we'd like to hear your concluding thoughts. Okay, till we reach him.
Dr. Vipin Puri is there. Why don't you ask him some questions? He's the VC there.
Oh, I could not see on my screen. But good evening, sir, and welcome to the discussion. We didn't realize when you joined in, my screen is limited. Sir, your words of advice and insights on use of health informatics and artificial intelligence in the healthcare domain. I still can't see him on my screen.
He joined, I think, but now I cannot see him on the participant list.
Right. We have some faculty from Mahatma Gandhi Institute. Abhishek and Anisha were here. What are the challenges you face when you reach out for training in health informatics?
Challenges, especially sir, culture. Actually, we are working in a is made by the top level management or
Abhishek, your voice is distorted. Maybe you're in a poor connection area.
So the focus is on the most revenue generated programs. Are you getting me, sir?
Yeah, better now. Yeah.
Especially working in a medical university, sir, the focus is always on the most revenue generated courses or programs. So basically, the most important challenge is to get the people and make them data literate and to convey our thoughts to a clinician, basically, because in daily routine activities, it is very typical to convey our thoughts for them. And what we have started, that we are connecting with the medical college peoples, physiotherapists, occupational therapists, and with the help of short-term courses, elective courses, value-added courses, we are trying to aware the people about the data literacy and the importance of clinical data.
Right. Thank you, Abhishek. Thank you for sharing your inputs. Dr. Richa, we have, I think, Dr. Malhotra here, who's a neurologist, you mentioned.
Yes, sir.
Yeah, yeah. Dr. Malhotra, let me reach out to you. As a clinician, what are the problems you would like artificial intelligence to address?
Yep.
What is your wish list?
Actually, as Dr. Richa initially said, we have worked on developing a model, and that model was based on, that was during the COVID times. That was an artificial intelligence model on detecting the COVID-19 just based on plain X-rays. And we had presented this to the state government also, and that was done in collaboration with the Abul Kalam Azad Technical University. So my experience on that model, and we are also working currently on a couple of artificial intelligence models on our patients who are having movement disorders, who are having tremors, who are having abnormalities while walking, and this is being done with the IIT Kanpur. The basic things, these are, one of the few things that we have been doing. The most important thing that maybe we have not discussed is validation of the models, developing or seeking what is the accuracy that we can achieve. So the thing is, like, when we started having x-rays of patients of COVID-19, the importance of detecting normalcy in those X-rays is also of equal importance besides detecting the abnormal X-rays. And that is how you best define what is the kind of accuracy. So this is one thing, and validating this in a cohort is something which is very important. Other things which we are planning to work, in neurology, the wish list is actually very wide to be true, because you have a lot of disorders, and most of them are degenerative disorders. And we have been trying to collaborate with Dr. Shrikant also, looking at the models which are looking at dementia, mild cognitive impairment. With movement disorders, we have already started. We have a Swedish group which is collaborating with KGMC as well as with IIT Kanpur on this thing. So maybe these are my thoughts on the AI models.
Thank you for sharing your thoughts, Dr. Malhotra. I'll reach out to Dr. Puri here. There's a very important point brought up by Dr. Malhotra here, that it's very important to know which are normal X-rays and which are not normal X-rays. I think you were talking about this aspect during your introduction. Would you like to elaborate a little bit?
Yeah, I mean, what we see, the metrics that are seen are accuracy, precision, recall, and F1 score. Now, accuracy is not something that we really want to see at, because it may give you a wrong evaluation of the model. The precision and recall become very important. Recall is very, very important in medical line, because we don't want to have false negatives. We don't want to miss a diagnosis. So these are the metrics that you use. And then what happens is, like, say, suppose you have a model which is seeing an image and giving you the diagnosis. Now, that model has its own accuracy, precision, recall, F1 score and all. So when you start giving images to the model, I mean, you automatically come to know as to whether it has given you the correct image or not. What the doctors have to learn is to see why it gave that diagnosis. So when you ask the model why, just like I showed, if is it a cat, or is there a cat in the image? And the model says, yes, it is there. It is showing you the area which it has seen as a cat. So the same way, the model can tell you what area, see, it's a brain tumor, what area did it see, and give you the result. So that adds to the trust. This is another way of validating the models. The IT people don't tell us this thing, but from a clinician point of view, it is very important to visualize the model. What did it see? Get the heat map, or these are called class activation maps, or the gradient weighted class activation maps, or GradCam, so that you come to know what did the model see, why it gave the diagnosis. So amount of tremors, we may see, a clinician may just see the tremor and say, okay, now after treatment, it has come down. No, how much has it come down? What has exactly come down? That can be quantized. And this again can be done in telemedicine also. In a quantization of data, that is so important. Quantization of disease, sorry. So that is very important, so that you know how your treatment is effective. Are you going on the right side or not? Same way, like you have a volume of a tumor that is quantized, so that you know with the treatment, has it really come down or has it increased? Let's be sure about it. So that is where it really helps, and AI can see all that even better than us.
Thank you very much for putting it in perspective. There's things like clinical explainability failure also, which is part of AI models. Explainability failure ratio is also part of it. So many safeguards are built into it. And you did mention auditing of the data, is also done. And you brought in the aspect of tremors. There are AI models which are now capable of picking up tremors in the way you use your mouse on the computer. So
something might go and somebody may come out with something, and if that turns out to be a breach of data, it's going to be a major problem, unexpected expense
on the healthcare system. Thank you very much for sharing those insights.
One more point that I would add is, since we are on the